Somebody say yes. Today we're going to talk about pediatric inflammatory bowel disease. I know you guys wanted to talk about autoimmune disorders. One of the common autoimmune disorders you guys are going to see is pediatric inflammatory bowel disease. I think all of you have seen one or two cases already this year, right? So pediatric inflammatory bowel disease is becoming more and more prevalent. We're going to talk a little bit more about this epidemiology and pathophysiology and genetic markers for that. Then we'll go on to the clinical presentation and therapy. We'll finish with the therapy. Okay. As we go along, we'll talk a little bit, I will mention a little bit about the other autoimmune disorders as well. Now, the epidemiology of the disease, as you know, it's been going up gradually, and currently it's probably prevalent throughout the world, even though in here we only see a couple of areas marked here: United States and Canada, mostly Europe, and maybe Australia and South Africa and things like Japan, mostly developed countries, right? On the other hand, more and more cases are reported more in India, China, and Brazil. Wherever there is more and more advancing developments taking place, there is increased incidence of Crohn's disease as well as ulcerative colitis. Crohn's disease appears to be more common than ulcerative colitis in the developing countries. Okay. At this point, I think the population is about prevalence of the disease about 53 people per 100,000 population. That jumped up from 42.1 in around 1995 to 2005, it jumped up. So it's gradually going up. It still continues to grow up as well. It appears as though more and more the change in the diet, that seems to be the trigger for increasing incidence of the Crohn's disease. This is the onset of the disease. As you can see, it seems to be anywhere from between 15 to 25 is the most common area. Time for the incidence of the disease peak is around 20 years of age. We used to say there is a second peak around 50 to 60, but it appears as though it might have been the patients that are previously misdiagnosed or were not diagnosed before. Now that curve is gone now. So most of the incidence is pediatric issues. So we are the ones that are making the diagnosis, and we have to be aware of this, the disease and disease presentation, etc. Right. It is estimated that about 25% of the IBD occurs in childhood, but 1.4 million people in the United States at this point at any time have the inflammatory bowel disease. And about 5,000 children every year are diagnosed with Crohn's disease, and 50,000 to 100,000 children are in the United States with Crohn's disease. This is probably higher because this data is around 2010 data. Now, the increasing incidence of the Crohn's disease, if you can see that this kind of shows you the multiple autoimmune disorders, you can see that all of them are going up. But if you look at the Crohn's disease, it's growing about 3 times faster than other autoimmune disorders. Probably second one is probably the type 1 diabetes is probably the second one. Okay. Here we don't list the celiac disease because celiac disease became more prominent more recently in 2005 when this testing came about, serological testing came about. That's when we started saying celiac disease is much more common than what we are thinking at this point, what we were thinking before. Now, the Crohn's disease presentation is different in pediatric age group. It behaves differently than in adults. Okay, The colon is most involved in pediatric Crohn's disease. Diffuse disease is very common, okay? And it's rather progression from during the first decade is fairly common as well. But on the other hand, the ileum is the most commonly involved in adults. And disease extension is less common in those patients, in adults. Ulcerative colitis, on the other hand, is pancolonic disease, can be more common in pediatric age group, and shorter time to diagnosis to surgery because most of them are presenting with aggressive pancolonic disease, so they might not respond well to therapy. They might go to surgery quicker than adults. On the other hand, if you look at the adults, it's localized to the left side of disease. And time to surgery is about 50 years. It probably is not entirely true because there are higher incidence. Once you go beyond 5 to 7 years, the incidence of dysplasia in the colon goes up, especially in ulcerative colitis. So it may be higher, maybe the surgery may not be due to ulcerative colitis, maybe due to complications of that. Now, the pathogenesis of the Crohn's disease is probably multifactorial. Okay, we need to have genetic predisposition, and there should be some abnormalities in the mucosal immune system secondary to genetic predisposition, and there is environmental factors has to play a role, and that leads to IBD. As we saw, the more hygienic the environment is, higher the incidence of Crohn's disease. So in the developing countries, you have more hygienic environment. Developed countries, rather, you see, you have a higher, more hygienic environment. That's where you see higher incidence of Crohn's disease. Also, ulcerative colitis is not so much. Crohn's disease tends to be associated with that more specific. Now, how does it cause disease? Normal host, if you get the environmental trigger, there's a tolerance and there is controlled inflammation and then resolves without a problem. Okay. So when you get the acute injury, the normal host will respond with complete healing. But if you have a genetically susceptible host, they have a higher incidence of chronic inflammation in that due to genetic susceptibility that leads to the disease. The luminal bacteria may play a role in here. That's why we talk about probiotics and things in these patients. Both Crohn's disease and ulcerative colitis is a polygenic disease. There is a significant number of genes that are upregulated or downregulated. There are a couple of them are very well organized and they are more associated with Crohn's disease. As you can see in CD, ulcerative colitis, relative risk of sibling being affected is higher than ulcerative colitis. Affected relative is likely to be 15 to 20%. So there is some genetic linkage in the family. Younger the onset, more likely you'll have a family history of inflammatory disease. There's a twin concordance rate very high in Crohn's disease, but not in ulcerative colitis. So obviously genetic influence is lower in ulcerative colitis than Crohn's disease. There are two genes that are identified specifically for Crohn's disease, not to COD15 most widely replicated CD susceptibility gene. Okay, IBD5 locus on the chromosome 5 appears to be associated with it as well. There are multiple sites identified with new technology, genome-wide association, SNPRA. And there are 32 loci associated with Crohn's disease, 17 with ulcerative colitis. So still there's a lot of research going on in this area. So we may come up with a better solutions, better options for treatment based on the genetic susceptibility in the future. Now, moving on to diagnosis, the presentation is a little bit variable between Crohn's disease and ulcerative colitis. As you can see, rectal bleeding is a predominant presentation in ulcerative colitis, but not as much in Crohn's disease. Abdominal pain is more common in Crohn's disease, and it tends to be more chronic than in ulcerative colitis. Diarrhea is much more common in Crohn's disease, ulcerative colitis than in Crohn's disease. And weight loss is much more common in Crohn's disease versus ulcerative colitis. That's probably because of acuity of presentation. Ulcerative colitis patients are going to present with acute onset diarrhea and blood, and they're going to come to the physician quicker. So obviously they're going to be not lose as much weight. So secondary to the same chronicity, you're going to see growth failure appear to be more common in Crohn's disease versus ulcerative colitis. Perianal disease, not seen in ulcerative colitis, but often seen in Crohn's disease. So anytime you see an examine a patient and you see a perianal disease, but the presentation appears to be acute bloody diarrhea, always think about Crohn's disease as a primary diagnosis, not necessarily ulcerative colitis as a primary diagnosis. Aphthous ulcerations are more common in Crohn's disease, but not as common in the ulcerative colitis. Other skin manifestations, erythema nodosum, both in Crohn's disease and ulcerative colitis. But pyoderma gangrenosum, it's not listed there, is another skin complication that's more common in Crohn's disease than ulcerative colitis. Obviously, anemia is going to be common both in ulcerative colitis and Crohn's disease, but type of anemia is going to be different between these two, right? In Crohn's disease, it's a chronic long-term loss, either due to malabsorption of the nutrients and anemia, iron, and as well as chronic blood loss, as opposed to ulcerative colitis, where its blood loss is going to be acute. So in Crohn's disease, you're going to see microcytic iron deficiency anemia. But on the other hand, ulcerative colitis, you're going to see normocytic acute blood loss anemia. Arthritis is more common in both conditions as well. So how are you going to make a diagnosis? Suspect the diagnosis. That is the first thing. Good history and physical. Then think about the diagnosis first. Okay. And anytime you're seeing a patient, that's often, we'll see that in Crohn's disease patients often, they will come to you with a significant presentation with hypoalbuminemia, severe anemia, all those things. But if you go back and ask them the history, they're going to say, oh, I had the stomach pain last month. I always used to run to the bathroom whenever I ate because it's been going on for several months. I always thought it's something that ate or something like that. So they usually not pay attention to the chronicity of the disease. Unfortunately, us physicians are also do the same problem. When the patient goes to the physician, they say, look at it and say, oh, you probably had a stomach bug. You're better now, so don't worry about it. Let's see what happens. So I have had patients that had 3-4 years of disease continue to go to the physician and say this each time, every once a month, they will go with a flare. Each time say, oh, you just had a bad stomach bug. That's all. You're better now. That type of thing. So eventually they will present with the severe disease. Right? Once we think about it, then we need to confirm the diagnosis. The first we start with the blood work, and CBC, cell rate, and CRP is going to give you the initial anemia presentation and cell rate elevation, CRP elevation. Hypoalbuminemia is more common in Crohn's disease than in ulcerative colitis due to acuity of presentation. Then obviously, if somebody presenting acutely, like in ulcerative colitis, you do want to rule out any infectious crosses in them. So usually you'll do a stool culture or C. difficile. But I'm more a fan of stool PCR that gives you rather quick diagnosis, and then you can go on to work up the patient. TB skin test more commonly in Crohn's disease patients rather than ulcerative colitis patients, because the presentation terminal ileitis can be a similar presentation that you will see in TB ileitis as well. Then we need to classify whether it is ulcerative colitis or Crohn's disease. Then once we think it is Crohn's disease, we need to determine the disease location. That's where the upper endoscopy, colonoscopy, upper GI small bowel follow through come into play. Nowadays, we spend more on the MREs. Is much more better localization than upper GI does. And if then you start looking at the extraintestinal manifestations, the liver function test, joint symptoms, you want to find out skin and eye exams if they have any photophobia or anything like that. Then you do need to look into those things. So once you made went through this workup, then you've made a diagnosis. So our initial laboratory evaluation, there's the main things that we look at. Because of the common nature of the celiac disease, we do want to go ahead and rule that out, number one. Number two, since it is another autoimmune disorder, it can be coexistent with the same patient as well. So I've had several patients that have, at least 9 patients that had both diseases, unfortunately. Now, there are certain infections, especially in ulcerative colitis, that you do want to make sure that you rule that out. Salmonella, Shigella, Yersinia, Campylobacter are the disease that we present with colitis as a main presentation. E. coli O157, we don't see that often. We saw that for rather frequently about the last decade. Now we don't see that as often. Entamoeba histolytica is not very common in the United States, but if somebody has traveled from somewhere else, sorry about that. Travel to Cancun or someplace and then come back with acute disease, then you do want to think about it as well. The 2 diseases the infections that we do want to think about, especially if somebody has a chronic disease, is tuberculosis and Yersinia. You need to be aware of the tuberculosis a little bit more nowadays, even in the United States, because of the more and more propensity for people going into organic eating. That means they're going to start drinking fresh milk off the cows. That's a big deal now, okay? So that they can get bovine tuberculosis. Bovine tuberculosis often tend to be ileitis rather than lung disease. So Yersinia is another condition that can present. It's considered great mimicker. It can present like with symptoms of appendicitis, ileitis, acute infectious colitis. So we need to rule out Yersinia. The problem with Yersinia, the other reason why I like the stool PCR is that Yersinia is a slow-growing bacteria. If you're going to wait on a culture, it's going to take 21 days before they call it negative, okay? But on the other hand, if you do a PCR, if you see the Yersinia DNA in there, they pick it up rather quickly. Within 24 hours, you'll find out. Now, serological testing for the confirmed diagnosis. This is still a developing field, essentially. There are multiple serological markers that are available to us, but not all of them are pathognomonic or make a diagnosis for definitively. We do need to use an algorithm to kind of mix up several different the serological markers together to say if it is Crohn's disease or ulcerative colitis, or whether it is not, or whether it is. So the antibodies are present in serum of all IBD patients. It could be immune response to the resident or bacteria, because most of the abnormalities you see is the antibodies you see are against the bacteria or fungi. Okay. Now, as anti-cerevisiae, sarcomyces cerevisiae antibodies, these are all nuclear antibodies for the, and these are once again are not really good markers. I don't really rely on them. If I have a kid that has a questionable disease presentation, whether, for example, somebody went to South America on a cruise and then came back with an acute onset bloody diarrhea, and I did all my testing, the testing come back, do colonoscopy, the biopsies come back, cryptitis. Now I got a patient with a questionable infection versus questionable inflammatory bowel disease. There I might do a IBD serology that might give me a pathway and say, okay, this does look like ulcerative colitis. Then I'll be comfortable treating the patient. On the other hand, somebody has a clinical presentation of a Crohn's disease, short stature, chronic abdominal pain, et cetera, and it goes through full workup. And all we find is a little bit of inflammation in his colon. And now we got stuck with a patient with a possible diagnosis of Crohn's disease, but no definitive evidence of that. There you can do a serology, and then serology shows that yes, he does have an IBD, then we can comfortably treat him, because once you put a diagnosis, then you have to treat them, number one, and the diagnosis is permanent. So you need to be sure of your diagnosis. Now, endoscopic findings as are X-ray findings and Crohn's disease and ulcerative colitis. Crohn's disease, any part of the GI tract. It's discontinuous, there is skip lesions. There's rectal sparing often, not always. The pathognomonic finding in the pathology is the non-caseating granuloma. And there is transmural inflammation. This is more of a surgical resection finding rather than a colonoscopic or biopsy finding. If I got a transmural inflammation on my biopsies, I perforate the patient. So, our perianal disease, fistula and abscess, our strictures are fairly common in Crohn's disease, and ileum is commonly involved. Perianal disease is often seen in this. On the other hand, ulcerative colitis, colon only, continuous disease. There is no rectal sparing. Often it starts from the bottom and goes up. On rare occasion, we may see some disease that's not as intense in the rectum, almost looks like rectal sparing, even in ulcerative colitis. But there will never be granulomas. So that is a major thing that you guys have to remember. There's a board question. Okay. So anytime you see a granuloma in a colonic biopsy, immediately pathologist is going to call that as a Crohn's disease. And mucosal inflammation, that's not a transmural inflammation. In ulcerative colitis, abscesses or big abscesses are rare, but there's a little bit of inflammation in the mucosa. The pathologist is going to call that as a crypt abscesses and crypt changes. Okay, strictures are very rare. This picture has been here, has been on board tests since I took the boards. That's about 40 years ago. So you see this terminal, there's upper GI small bowel follow through. You see the terminal ileum with the ragged edges here and the ragged edges there, and then continues. That's dilatation of the ileum here. Okay. That's the terminal ileitis. It's a colonoscopic finding of the ileum. There is a normal ileum. There's these little nodules you are seeing, the lymphoid patches. You see another patches, Peyer's patches here. Okay. On the other hand, patient with ileitis, you will see a long serpiginous ulcers. Okay, a little bit of cobblestoning, and a lot of exudate throughout the colon, throughout the area. Cobblestoning essentially is swelling of the mucosa. So when there is quite a bit of inflammation, there's also the next to it, there's swelling of the mucosa, it pops up. Okay, so essentially this one, this area, you see a little narrow patch of exudate in between. This can be considered cobblestoning. Here there's another area. Oh, you can't. I'm sorry about that. See this exudate here. Okay? So that's like cobblestones. On the other hand, in the colon, there is a normal colon. Okay, as you can see, there is a triangular appearance. That's usually transverse colon has the triangular folds. You can see that vasculature. You can see clearly. Okay, and so there is normal vascularity. There is normal tortuosity of the colon, and there's normal folds in the colon. Okay, that is a normal. First picture is a colon. Okay. Second one is an ulcerative colitis, the middle one. There is a loss of vascular pattern. You don't see the vessels anymore because of the swollen mucosa. And there's a little bit of granularity. Okay, there may be small touch of exudates here and there. Okay, and the disease seems to be continuous in throughout the colon. Okay, continuous inflammation. Okay, on the other hand, Crohn's disease, you can see the deficiency of here. Going up and down, the cobblestoning here, as it gets set up. And you can also see that there's a skip area. There is a little area. Actually, here, you look higher up, there you can see vascular pattern. So that lining is going to look normal. So obviously we're going to say the cobblestoning segmental distribution that we saw showing there. Rectal sparing, often we'll see that. It's not shown in this picture. And you'll see ileal involvement. And one thing about it, if somebody has a pancolitis, okay, this disease is in ulcerative colitis, if they have inflammation throughout the colon, even in the ceca. In those conditions, occasionally you will see some inflammation in the terminal ileum too, that extends into the terminal ileum. It doesn't mean that it's ulcerative colitis is extending into the ileum. It's just what we call backwash ileitis. Some amount of ileum inflammation is extending in there, but it's not going to be. Once you treat them, that's going to go away completely. So obviously, the granulomas on biopsy is the most pathognomonic finding. All right. Now, the extraintestinal manifestations, arthritis, arthralgias, ankylosing spondylitis, sacroiliitis, all those things. That's those things that you guys read about in third year, second year. Chills. Erythema nodosum, pyoderma gangrenosum. Cutaneous vasculitis is not that commonly seen in pediatric age group patients, but it's fairly common in adults. And once again, uveitis, episcleritis, retinal vasculitis. Retinal vasculitis, once again, is older people, but you will see uveitis and episcleritis in younger children as well. Aphthous ulceration and cheilitis are fairly common in Crohn's disease, not as common in ulcerative colitis. Similarly, salivary gland involvement is also common in Crohn's disease, but not as common in ulcerative colitis. Hepatobiliary changes, both the primary sclerosing cholangitis as well as autoimmune hepatitis is more common in ulcerative colitis than in Crohn's disease. We'll see more common association of primary sclerosing cholangitis with inflammatory bowel disease than autoimmune disease itself, autoimmune hepatitis itself. Next slide shows the episcleritis. You can see that. Here is the erythema nodosa. So that is very painful, very tender nodules on the shin or the long bones of the essentially. Most of the time it's on the shin. Now the growth failure is, as I said, is fairly common in Crohn's disease, not as common in ulcerative colitis. It depends upon when we see the disease, what is the presentation of the disease, the amount of growth failure change. So you here to see if you use a pediatric IBD, occurrence is about 35%. Okay. On the other hand, if this Crohn's disease presents before puberty, it goes as high as 60 to 85% of it. Okay. Even if you make a diagnosis fairly early in these patients, you will still won't be able to achieve the mid-parental height, which is the normal goal of growth. Okay. That's mainly because of our therapy. Number one, the loss of nutrition, the loss of growth initially, and then our therapy, usually steroids, etc., will interfere with the growth as well. Okay. On the other hand, the children with ulcerative colitis, growth failure is very much less than Crohn's disease. Basically, the growth failure in ulcerative colitis is for the patients that have been treated extensively with steroids rather than disease itself. So here is a decreased growth velocity reported even before the onset of gastrointestinal symptoms, especially in Crohn's disease, you can see here. Okay. And then diagnosis was made here at the bottom of so this is the so there's velocity even before, and once we make diagnosis, treatment is fantastic. Okay. So even before the onset of this disease symptoms, we can see that. So what is the cause for the growth failure? Yes, in inflammatory bowel disease. As we mentioned, therapy is also a major role. There are multiple factors in there. So, as I said, each time these patients usually have symptoms of eating and then having pain, so they stop eating. So suboptimal intake. And they may have diarrhea, so they have a malabsorption of the nutrients. So they have increased caloric losses, all right? Because of the disease itself, the caloric needs are higher. So that's another cause. Now, due to the therapy that we do, the steroids, that causes growth delay. Chronic inflammation interferes with the growth. Okay. Pubertal delay, either because of all of this or by itself, so delayed puberty itself will interfere with growth as well. They won't be growing as much because of the lack of all the hormones. So next we'll go on to the therapy. Okay. Our goals of therapy is to maximize the therapeutic response, maximize the adherence, because this is a chronic disease. It's very important that we be aggressive in treating these patients and also making sure that they continue to adhere to their treatment regimen, because without the treatment regimen, they will flare up again, continue to have problems. Okay. And the medications that we are fairly toxic, fairly immunosuppressive. Our goal is to minimize the toxicity. And primary goal of all of this therapy is to improve the quality of life. It should be asymptomatic. We should achieve at maximal growth and pivotal development. Okay. And because in a patient that's got chronic disease, chronic multiple repeated absences in school, repeated hospitalizations, you don't need to worry about the psychological development as well. So we need to intervene as soon as possible. And obviously, disease complications is another thing that we need to worry about. So the therapy for inflammatory bowel disease has evolved over the past 30, 40 years. Okay. Now, mild to moderate Crohn's disease, we can treat with still we can do with aminosalicylates, antibiotics, the enteral nutrition, corticosteroids, and budesonide and prednisone, etc., to control the symptoms. Okay. Moderate to severe, we can start with enteral therapy. The enteral therapy is where you are going to ask the patient to stop eating regular diet, go on to polymeric special formula that they have to consume for about 8 weeks. Okay, so there was a special preparation called modulin but each can is about 240 calories, just like regular other formulas are. That you drink about 8 cans a day. That's 2,000 calories a day for 8 weeks. Okay. Once they were induced, then we can add some of the regular diet back into the regimen, but you need to maintain them. The enteral therapy is now considered one of the options for therapy now. Okay. It used to be that we just tried it as a research tool. Now more and more people are opting for that. And that's probably is going to be one of the therapies we will offer the patients from now on. Okay. Now, this other drug that we use for quick induction, all of you are aware, is the steroids. Yeah. So you guys probably seen the response that you see, especially when you use IV steroids in these patients. Okay. Depending upon the disease, how aggressive, how severe the disease is, the response is the pure steroids may or may not respond because they should be able to absorb the medication for them to respond. So that's why when you put them on IV Solumetrol for at least 48 hours, you see a dramatic response. And you switch them to the PO medication, you may see a relapse of their symptoms. So that's why we always want you guys to put them on IV steroids and then watch them for 24 hours on PO because they will quickly relapse after that. Okay. So the therapy that we use, either budesonide or prednisone. Budesonide, there is a pure preparation available, and that is the budesonide is not absorbed through the GI tract, so we think it mostly works in the GI tract by itself, okay, locally, and it doesn't cause any of the other side effects of steroids, mineralocorticoid deficiency and things like that, those changes and things, we may not see that. Okay. Now, next we move on to immunomodulators. Immunomodulators are the ones that are 6-mercaptopurine as a thiopurine or methotrexate or the immunomodulators. These are used more for maintenance of the therapy rather than induction because they don't work as fast. So we start them on steroids and then add the immunomodulators at about the same time. But as they get better, and we withdraw the steroids and then continue the immunomodulators, okay, so that we can maintain them on that. What is the good thing about using immunomodulators? You have a steroid sparing effect. They still respond well to therapy. Okay. They can be maintained with just the mild immunosuppression because you don't see as much of immunosuppression with the immunomodulators versus biologics. Okay. Now, 6-mercaptopurine azathioprine can be monitored. We can monitor their levels, their therapeutic levels. Okay. And methotrexate, you do need to watch out for the liver fibrosis and liver disease. Okay. Biologics, this is a new set of drugs that is available to us. The infliximab has been around since about 1994. Okay, so it's been about 26 years now, so we got good experience with it. Adalimumab, certolizumab, and we got multiple other medications now, not just these three now. But actually, these are the only three that are authorized for pediatric use now. These aminosalicylase multiple preparations, and you can see that there is a time-released one, pH-released one. So depending upon the company that makes it and the insurance company that allows you to use it, we use it different preparations. Okay. The important thing to remember, most of these aminosalicylase are formulated so that the capsules get broken down in the distal part of your small intestine. So it's useful more for the colonic disease than for proximal bowel disease. So there's a study that's showing that mesalamine can maintain remission in Crohn's disease. As you can see, favors treatment a little bit towards the left. Okay, favors control good. Okay. The endogenous gut flora, especially in Crohn's disease, they think that the gut flora does play a role. Okay, that we use antibiotics just to alter the gut flora, not really to treat any particular infection. That's why when we say Flagyl 3 weeks or any other antibiotics for 3 weeks, because we treat it, our goal is to alter it. We also don't use as much of Flagyl, same dose as if you are treating an infection. Our dose of Flagyl may be 250 milligrams twice a day for 21 days. Okay. So mainly the idea is to change. We're thinking that there may be some bacterial invasion or translocation or systemic dissemination that's maybe the cause for causing the immunogenicity and then causes the autoimmune response. Our goal is to change that. So it's only an adjuvant therapy. Now, nutritional therapy, enteral therapy, we just talked about, and it's been shown to be efficacious in inducing as well as maintaining the disease response as much as 82% of the patients, especially Crohn's disease. It's not useful in ulcerative colitis. So don't try to use the enteric therapy in ulcerative colitis. Okay. And nowadays, before we used the elemental diet only, now we can use polymeric diet as well. So you can use Peptamen Junior versus Neocate Junior. Okay, so there is no difference. So this is a comparative study between prednisone to induce remission in these patients. As you can see, both the steroids and the enteral nutrition are about the same in response. This is a good combination of data from the multiple studies. So important thing to remember about steroids. Steroids are never used as a monotherapy or maintenance therapy. Okay, they usually you need to use it for induction and for occasional flare-up. Okay, the therapeutic dose has to be adequate. Okay, you need to give them 60 milligrams if needed. Okay, and they are not the maintenance drugs. Okay? Don't rely on them to treat the patient, maintain the patients. As this one is going to show the response rates for steroids. You can see the complete remission in 58%, but we'll skip this one. We got 10 minutes. All right, biologic therapy, immunomodulators and biologics for Crohn's disease. Indication as induction and remission and maintenance. Okay. These are more commonly used, especially the biologic therapy as a to induce the response is if somebody has a fistulizing disease or severe inflammatory process or severe perianal disease. Those patients, we start with biologic therapy as an initial induction and then maintenance. Okay. It also reduces the corticosteroid dependence and resistance because it's better. Okay. And you can also use it to as especially immunomodulators, you can use them to delay the recurrence of the disease after post-operative period. Okay. So that is the third part, prevention of post-operative recurrence. Okay. And once if they have recurrence after post-operative period, you usually want to go with the biologic therapy to treat them. Now, therapy with the dosing for immunomodulators, 6 mercaptopurine, 1 to 1.5 milligrams per kg per day oral. Thiopurine, 2 to 2.5 milligrams per kg oral. And methotrexate, 15 milligrams. And for sub-Q injection once a week as induction, and then 10 milligrams per meter square per week as a maintenance. In all these conditions, you have to use folic acid supplementation, including mesalamine therapy. This is a diet study comparing the 6-MP remission and then maintenance. As you can see, there's significant difference between the control group and 6-MP group. There are adverse events associated with thiopurine. The major things are the gastrointestinal nausea and vomiting is the most common thing. But one thing that we always worry about in thiopurine use is the pancreatitis. Usually the pancreatitis is an acute onset problem. It happens mostly in the first 3 to 4 days of them taking the medication. So we always tell them, if you start having acute onset pain, that's the different area. Usually it's epigastric because of the pancreatic pain. When you start taking this pill, call us immediately. So we stop the therapy. We cannot use that anymore. Okay, we cannot reduce the dose and see if it works. That cannot be because this is an idiosyncratic reaction. So once they have a pancreatitis symptom, you cannot use any immunomodulators. The other thing that we worry about is the anemia, or they can develop pancytopenia, bone marrow suppression. So we do need to monitor that CBCs. And obviously we need to monitor their liver profile as well. Okay, there is a higher incidence of non-melanotic melanomas, skin cancers in these patients. So they have to use sunscreens, and those are long sunscreens. Same case with the mesalamine therapy too. All right, the biologic therapy, the most commonly used now in pediatric age group are these three. Okay, infliximab, adalimumab, tocilizumab. All of them are TNF, anti-TNF agents. Okay, we have most experience with the infliximab, then the adalimumab, which is Humira. There's initial studies, REACH studies that's shown that pediatric age group patients actually respond better than adults to biologic therapy. Okay. But the remission rate is also much better after the initiation of therapy. The complications that we are worried about are the infusion reactions or development of antibodies and other response. Okay. There is one specific lymphoma that can occur with patients with when you use biologic therapy. That is HSTCL. Okay. This is non-Hodgkin's lymphoma. These patients don't respond well to therapy. That's been uniformly fatal in this particular lymphoma. Okay, so these lymphomas seem to develop in male population, and also if they have a concordance use of immunomodulators along with the biologic therapy. So we stopped using immunomodulators in these biologic therapy patients now, especially if it's male. In female, they still continue to use it. They can still continue to use it. Female patients can continue to take immunomodulators as well as that. But when I say immunomodulators, it's only with the azathioprine 6-MP that we saw this association. So we don't see that with the methotrexate. So we do use methotrexate in these patients. So for ulcerative colitis, mild to moderate disease, aminosalicylates, moderate to severe corticosteroids, and then we can use the biologic immunomodulators to maintain them. So this is what I was talking about, the different preparations that are start releasing their active moieties in different areas of the small bowel. This is a study that's showing the maintenance therapy for ulcerative colitis using mesalamine. As you can see, there's a different, there's still AAC is better than placebo. We'll skip that one. For biologics, for the ulcerative colitis, infliximab. Now the Humira is also approved for pediatric age group just recently, so we can use Humira as well. Until now, we could only use infliximab. Surgery, something that we go to only rarely. In surgical indications in Crohn's disease, failure of medical therapy. If somebody has a stricturing disease, recurrent obstruction, perforation or fistula or abscesses that are not getting better with your therapy, if they have severe hemorrhage. On rare occasion, it's this growth retardation indication is very rare. On rare occasion, we may use that when we have failed medical therapy, we are not able to. This may be used more often in the future, especially because we are seeing more and more patients that are presenting very early. Okay. What we call as a very early onset inflammatory bowel disease. Carcinoma is very bit rare in Crohn's disease, but it can occur. Surgical indication in ulcerative colitis, exsanguinated hemorrhage, perforation, or cancer or dysplasia. That is a more common indication. Cancer dysplasia is more common indications, mostly in adults, because we don't see them, because that tend to occur only after 7 to 8 years of disease. Relative indications, medically refractory disease, steroid dependency, growth retardation because of the steroid use, other systemic complications, like a typhlitis or anything like that, they might develop. Vaccination in inflammatory bowel disease, we use vaccine schedule just as normal. Okay. So at least before you use biologics, there is no contraindications to use live vaccines. But if you're going to use live vaccine in a patient that's on biologic, we usually recommend that you skip a dose of biologic therapy. The live virus vaccine contraindicated, especially the flu vaccine. That one we tell them not to use the intranasal one. Okay. MMR, oral polio vaccine, varicella, those we don't recommend using it. Okay. Killed vaccines can be given a continuity schedule. You can even do that when they are on. All right, we're getting close. We're going to skip the bone disease and bone density. Bone disease is fairly common in children with Crohn's disease because of both poor mineral deposition. They may have early osteoporosis and things like that. And the use of long-term steroids will also do the same thing. Psychosocial issues and quality of life. But 30% of children will have some evidence of depression sometime during their life. Okay. And 10 to 30% of them meet the criteria for anxiety at any time whenever we see them. Okay. There is not an increased incidence of this depression or the anxiety in IBD patients when compared to any other chronic disease patients. All right. So what main thing is important of adherence. Okay. At any time we check the patients, the adherence rates falls gradually if you don't keep reinforcing them. Okay. That's why we see these patients fairly frequently in our therapy, during our therapy sessions. All right, we're going to skip there. These are all just. All right, any questions so far? Depending on what they are on therapy with. If somebody is on immunomodulators, you probably want to do that about once every 3 months or so. Okay. If they are on biologic therapy and they are doing well, we see them once every 6 months. We do that at the. Okay. But at least twice a year we do the blood counts. Okay. Yes. Good question. Now, at least until recently, the formulas that are available are not that well. So a lot of people used to get G tubes or NG tubes and get fed that way. CHOP, they have a enteral feeding therapy program. There, they actually teach the patients how to put their own NG tube. So every night the kids put an NG tube down and infuse themselves, and then you get up and put it out in the morning and go home, go to school. Okay, they do that as well. But I think the more recently the data has come out that you can use regular formulas as well. Something similar to like a Pediatric or Peppermint Junior with the multi-flavors. They seem to induce the same response as opposed to these specialized formulas. So, and also there is before we used to say for 8 weeks, you're just going to be on just this formula and then that's it. Now, more recently, there is some data that's coming out using about 50% of regular diet, 50% of this. So with this combination, we gradually will see that the therapy for inflammatory bowel disease is going to change from steroids and IV admission, things like that, to enteral nutrition versus biologic therapy. So depending upon the disease, how acute it is, how much the parents are willing to accept one of those options. Because often you'll see the parents coming and saying, oh, I don't want this dangerous, toxic medicine in my child. But there we don't have another option. Good. Yeah. That's definitely the case, okay, along with their nutritional deficiencies, okay. The one thing that we do is that once we are hitting 14 or 15, we are not able to achieve our remission and their growth and enough growth on them, we refer them to endocrinologists. So at least let them get some growth hormone shots, even though they are normal growth hormones, sometimes will be higher because of their negative stimulation. So we still let them go and get the shots. Go ahead. There is no definitive reason that's found. I think there's some of the, just like we are using the fecal transplant for even for ulcerative colitis or for the C. diff colitis. Okay, some of the microbiome does protect you. Okay, so the changes that we have when you are in a sterilized environment, probably the microbiome is different than what microbiome that you have, bacteria that you have in, say, the third world country. Okay, that seems to be okay. Maybe then we have more and more research coming out about immunogenicity, immune protection of the bacteria in the gut. Okay, so that there is definitely a role there. So good. See you guys. Okay.